The next paper is precision of a new intraoperative alignment tool for toric IOL. Presenting author is Dr. Ambika Shetty. Dr. Ambika Shetty, please.
Good morning, I'm Dr. Ambika, and my topic is to predict the precision of a new intraoperative alignment tool for toric IOLs. None of the authors have any financial interest in the study. Toric IOLs, as we know, provide the opportunity to correct pre-existing astigmatism, offering patients optimum uncorrected distance vision. Accurate intraoperative positioning is crucial for the alignment of toric IOLs, and each degree of error in alignment reduces the cylindrical power by approximately 3.3%. Some of the limitations of the conventional markers are that the alignment axis has to be manually marked. Most of them are contact methods. The markings are placed 5 degrees apart, making them less accurate. They have a longer learning curve and they are more surgeon dependent. The Z-Align, which is a part of the Callisto Eye digital surgical data system, uses a video overlay technique for accurate intraoperative positioning of toric IOLs. It uses a competitive eye tracker based on a live video image to mark and project parallel lines on the eyepiece of the microscope for the alignment. Our study aims to evaluate the precision of this tool. We included patients with regular corneal astigmatism more than 1 diopter and uncomplicated cataract surgery with in-the-bag placement of toric IOLs. We excluded patients with irregular astigmatism, any significant ocular surface or corneal pathology, and extensive macular disease or optic nerve disease. This was a prospective non-randomized case series of 36 eyes conducted at Nethadama Super Speciality Eye Hospital in Bangalore. The toric IOL power and axis was calculated using an online calculator. An expected amount of surgically induced astigmatism of 0.3 diopters was included. To correct for cyclotorsion, the 0 and 180 degrees was marked with patients sitting upright at the slit lamp. The first step involves marking the reference axis. The image you can see is that of the Z-Align module of the Callisto Eye digital surgical data system, and this is a touch screen. The first step is marking the 0-180 degree on the touch screen, following which the reference axis, that is depicted by these green dots and the yellow line appear. So this indicates the 0-180 degree axis. The next step is entering the target axis, along which we need the IOL to be placed. Following that, these 3 blue lines appear, which indicate the target axis. The final alignment of the IOL is achieved when the central blue line coincides with the marking of the toric IOL. Post-operatively, we studied the alignment using the Zaldivar caliper of the eye trace system, and then we analyzed the results, and out of 26 patients, 13 were males and 13 were females. Out of the 36 eyes operated, 10 patients underwent bilateral surgery. Mean age of the patients was 62.44 years. The mean preoperative refractive astigmatism was 2.25 diopters. The mean corneal astigmatism was 2.72 diopters. We studied the correlation between the intended and the achieved axis. As you can see, there's quite a close correlation between the intended and the achieved axis. Analysis of the alignment of the IOL showed that 91.67% of patients had alignment within 5 degrees of the intended axis, and the mean rate of misalignment was 3.33 degrees. We analyzed the post-operative astigmatism and saw that 91.67% had post-operative astigmatism within 0.5 diopters, out of which 72.22% had a post-operative astigmatism of 0.25 diopters. The mean post-operative astigmatism was 0.3 diopters. We compared the pre-operative best corrected visual acuity and the post-operative uncorrected visual acuity and saw that 97.22% had an unaided visual acuity of 6/9 or better, out of which 88.89% had an unaided of 6/6 or better. We compared our study to a similar such study which had used the Z-Align, which was conducted at Germany, and saw that we had a similar rate of misalignment with a median of 2 degrees. We compared our study with studies which had used the conventional markers, and we saw that we had a similar rate of misalignment, and we didn't have any patient with more than 10 degrees of misalignment. The advantages of the Z-align system are that as the overlay technique is real time, it makes it convenient and easy for the surgeon to view the Myers throughout the alignment process. The instruments and movements of the eye within the operating field do not interfere with the tracker because it automatically adapts to changes, including the zoom and focus during surgery. The IOL alignment can be made more precisely, up to 1 degree, compared to the conventional methods, which have up to 5 degrees. It's a non-touch technique and no extra time is required for the procedure. My take-home message would be that Z-align is a safe and precise technique. The outcome is predictable and comparable to the conventional methods. It makes the learning curve of toric IOL alignment much shorter. Thank you.
Thank you. Any questions? Okay. There's no time for...
Just one.
Yes, please.
You are marking the reference axis 180 degree with pen.
Yes.
This is not a non-touch technique. On table it's always non-touch.
On table it's non-touch, but this we are marking pre-operatively.
And how do you know that the 180 is 180? And it is going through the center of the cornea.
There's a time is short, we will discuss it later on. Please, thank you.
So our next paper is correlation between patient satisfaction and misalignment of the implanted MF5OL with respect to visual axis. Dr. Ankit Patil from Kolhapur.
Okay. Good morning, everyone. I'm Dr. Aniket. The topic of my presentation is clinical study of correlation between patient satisfaction and the misalignment of implanted multifocal IOLs with respect to the visual axis. I would like to clarify here that none of us have any financial interest in the said study. Multifocal IOLs, as you all know, deliver less than satisfactory visual acuity and quality along with more photic phenomena compared to the monofocal IOLs. Researchers have associated photic phenomena with retained lens fragment, posterior capsular opacification, dry eye syndrome, and postoperative astigmatism. Role of misalignment of implanted multifocal IOLs with respect to the visual axis as a specific predictor for patient symptoms has never been highlighted. To throw some light on the concept of misalignment, we need to brush up our knowledge about angle kappa and angle alpha. Now, angle kappa is the distance between the center of the pupil and the visual axis. In the figure on the left of your screen, figure A represents an eye with small angle kappa. Here, the foveocentric ray may pass through the central ring of the multifocal IOL. Figure B represents an eye with large angle kappa. Here, the foveocentric ray may hit on the edge of the ring, causing edge glare effects and deterioration in the quality of vision. Now, what is angle alpha? Angle alpha is the distance between the center of the limbus, which corresponds to the center of the bag, and the visual axis. In short, it is the angle between the visual and the optical axis at the nodal point of the eye. The same ray dynamics hold true here too. Current study was a retrospective, non-randomized cross-sectional clinical study carried out at Netradhama Super Speciality Eye Hospital, Bangalore. 50 eyes of the patients with implanted 80 Lisa 809M multifocal IOL were included in the study. All these patients were handed over a questionnaire to fill. These patients were further examined on eye-trace surgical workstation to calculate the angle kappa and angle alpha distance. We included patients who had undergone cataract surgery more than 6 months back, patients with uneventful cataract surgery with well-centered in the bag placement of the multifocal IOL. We excluded patients with posterior capsular opacification, posterior capsular phimosis, more than one diopter of astigmatism before surgery, any retinal or corneal pathology. Following is a questionnaire which was handed over to the patient. Questionnaire was basically to assess the satisfaction of the patient in terms of distance vision, intermediate vision, near vision, glare, and halos. We eventually got a total score out of 25. The point to remember here is lower the score, more satisfied the patient, and higher the score, more unsatisfied the patient. Males outnumbered the females. The mean duration since surgery was 2.55 years. The mean age of the patient was 67.89 years. Coming to the total satisfaction score, 62% had a score between 0 to 10, whereas 38% had a score between 11 to 15. None had a score of more than 16. Coming to the split analysis of each individual symptom, the mean distance vision score was 1.58. The mean intermediate vision score was 1. The mean near vision score was 0.74, which shows that majority of the patients enjoyed an excellent near vision. The mean glare score was 1.54. The mean halo score was 2.06. Halos was the most troublesome of all the symptoms. This is a graph showing correlation between the alpha distance and the total score. Here you can see as the alpha distance goes on increasing, the total score also goes on increasing. The Pearson's coefficient between the two variables is 0.487, which denotes a moderately strong correlation between the two variables. Now coming to the split analysis of angle alpha, 35 eyes had an angle alpha distance of less than 0.6. 17.14% of those had a total score of more than 10. 15 eyes had an angle alpha distance of more than 0.6. 86.67% of those had a total score of more than 10. What this means is 86.67% of the eyes with angle alpha distance more than 0.6 were not satisfied with their visual outcome. This again is a graph showing correlation between the kappa distance and the total score. Here again, as the kappa distance goes on increasing, the total score is also increasing. The Pearson's coefficient between the two variables is 0.789, which denotes a very strong correlation between the two variables. Coming to the split analysis of angle kappa, 40 eyes had angle kappa distance of less than 0.5. 25% of those had a total score of more than 10. 10 eyes had angle kappa distance of more than 0.5. 90% of those had a total score of more than 10. What this means again is 90% of the eyes with angle kappa distance more than 0.5 were not satisfied with their visual outcome. Hence, to have satisfactory results with multifocal IOLs, we should concentrate on the ways to reduce photic phenomenon and overall satisfaction score. As customized multifocal IOLs are not available, proper patient selection is of utmost importance. Our study suggests that there may be a correlation between misalignment of the implanted multifocal IOL with respect to the visual axis and patient satisfaction. My take-home message to all of you would be that measurement of angle kappa and alpha distance should be a routine protocol before multifocal IOL implantation, and patients with kappa distance more than 0.5 and alpha distance more than 0.6 should serve a red flag for implantation of multifocal IOLs. Thank you for your kind attention.
After listening to this talk, I don't think I can practice in my practice in the university. I'm not afraid, I know selection. Wonderful, yeah.
Thank you very much. Now we come to the end of this session, and I'm thankful to Dr. Ratan Kumar and Dr. Satyanarayana Raju, and of course Dr. V.K. Raju. Thank you very much to the audience, and we come to the end of the
Just
session.
to mention,
Please.
Cataracts still, 70% of cataracts, eye surgery is cataracts, right? All over the world. In ophthalmology, surgery means 70% of surgery is cataract related. With a beautiful study, I don't know whether research is always like this, whether it happens or not, but we have to proceed with a caution. What has been done before by our predecessors? They're doing, anybody is aware, there is a Scandinavian from I think Norway, there is a study, etching of the brown pigment from the lens. Anybody is aware? If you can etch, just remove the immature cataract when the cataract is forming, if you can etch a few minutes of slit lamp surgery with a topical anesthesia maybe, if you can etch and if you can prolong the cataract formation and keep the 20/40 vision in the Western countries, as you know, 20/40 is the driving vision. Everybody wants to drive. And we are having, similarly, car is a very important thing. 20/40, that means 6/12. If you can keep the 6/12 vision for another 6 to 7 years, maybe 6 to 8 years, half of the cataract surgeries won't be done in Western countries. Did you hear that? And things like that, you all have to think a little bit, rather than, these are wonderful, brilliant papers, but in a public health issue, these are all expensive. Once you make this multifocal lenses, toric lenses, and all the variants, these are all expensive. Probably still under these conditions, less than 20% of the people are accessible for them. 80% of the people in India will not be accessibility there. And as you know, doctor means, do you know meaning of doctor? Anybody? Doctor means what in Latin? Huh? Teacher, wonderful. We are first teachers, then giving the medications and surgeries and putting them to the operating room. If you do a piece of our time, similar little time in teaching, there's so many things. educating the patient is the most fundamental. Our practice will get better. Our relationship with the government will be better. And above all, we have done the right things for the patient. Think about, go to the internet and say, itching, brown pigment, cataract, and you go to the internet. All those papers are all there on the internet. Patient is looking at them, educated patients. If you can prolong the cataract formation for up to 6 to 8 years, half of the cataract surgeries will not be done. I'm talking about the Western cataracts, but we have some problem with the ultraviolet rays, and still there's so many people walk without ultraviolet filter. It doesn't make any sense to me how advanced we are in this country. And what with all the speeches, one of the papers was there with Tamil Nadu, working with the basic sciences, all your. So sure, I did not mark anywhere. I'll go with you a little bit. Okay, I'll go with you.
Welcome, friends.
Everything came from physics laboratories, all your MRIs and everything came, we're all using it. So we have to work with basic scientists. We do. We take it to another level. Thank you.
Thank you, Doctor.
Thank you. Sorry if I take your time.
Welcome, friends. We start the cataract 2 session. I am Dr. Chaudhary. Along with me is Dr. Subhash Prasad, Dr. Norman Mandacha, and Dr. Sudesh Kumar. Our first presenter is Dr. Ramesh Shah, my new design in diffractive multifocal eye.
Good morning, friends. Respected judges.
Electron microscopic study by Dr. Nilu Tapal Boram. Please.
Good morning, everybody. Good morning, sir. Good morning, everybody. I'll be presenting on morphological study of polymethyl methacrylate intraocular lens, a scanning electron microscopic study. I do not have any financial interest in this presentation. We know that SICS, which single-piece or multi-piece PMMA IOL implantation, is one of the most common surgeries in India and other developing countries. SICS is a safe, effective, and economical alternative to phaco due to low cost of PMMA IOLs. Average cost ranges from Rs 80 to 1,000. However, several studies show that following SICS, with PMMA implantation, incidence of PCO is higher than phaco implantation. In this background, we wanted to evaluate under scanning electron microscopy surface and edge characteristics of commercially available PMMA IOLs in India, and to see whether low-cost single-piece PMMA IOL have higher surface and edge irregularities compared to relatively expensive single-piece PMMA IOL, that is Rs 1,000 and above. We have studied the surface characteristics, that is morphology of 14 PMMA IOLs in SCM produced by Carl Zeiss company. Period was from January 2011 to February 2013. 14 IOLs were selected randomly and procured from the local medical agencies dealing with IOLs. IOLs were removed from the package carefully, then being mounted on the mount, then fixed with glue, then level. After the mount, they were sent for gold leveling. Here there is plasma formation and gold coating is in progress. After the gold coating, it is mounted under the electron gun in the SCM and the IOLs are ready for study. SEM photograph of optic haptic junctions, dialing hole, and optic edge were obtained at 160, 500, and 1000x magnifications. Images were saved in JPEG files and then studied individually. Surface defects were divided into mild, moderate, and severe degrees. Overall surface homogeneity was studied at 160 magnification. SEM was operated by a senior faculty at IIT Guwahati. Total, we have studied 14 IOLs, 12 low and 2 higher cost PMA IOLs. Irregularities, roughness, and unevenness, etc. were detected at the dialing holes in 13 IOLs, at the optic haptic junction in 11 IOLs, and the optic edge in 7 IOLs. At 160 magnification, central optical zone showed a smooth surface in all 14 IOLs. We didn't find any difference in surface irregularities between the low and high cost PMA IOLs. This is the master chart showing different magnification we have done and different IOLs and also different defects we detected. This bar diagram shows the irregularities and roughness were mostly confined in the dialing hole and optic haptic junctions, which were from the mild to severe degrees. This shows microphotographs shows irregular and rough dialing holes and serrated edge, and mostly they were confined in the dialing hole areas. These photographs of the optic haptic junction, their roughness, protrusions, softness, etc. is detected in different IOLs. At the optic edge, protrusions and deposits and roughness were detected, and these sharp protrusions may rupture the PC during dialing. International manufacturing standards says that the PMMA IOL should be free from surface defects and all edges should appear smooth. Kumbe R. et al. Has done a study on Indian IOLs, and they have found that only 5 out of 8 IOLs had good manufacturing quality, and they concluded that the non-clinical grade PMMA material may have been used by some producers in India. In this study of optic haptic junction dialing holes, optic edge showed mild to severe degree of defect, suggesting poor manufacturing process. 160 magnification we could detect in 5, in 500x, 11 in 1000x. All 14 PMMA IOLs showed scratches, fittings, sharp serrated protrusions, etc. 2 high-cost PMMA IOLs also showed the same nature of defects. These are the microphotographs of high-cost PMMA IOLs. You could see the fittings in here. And this is 160x magnification of the dialing hole, that unevenness of the surface, and there is scratching in here. Posterior chamber IOLs with a large posterior optic edge have been, which a square posterior optic edge have been associated with better PCO prevention than round edge IOLs. It may be due to a barrier effect. Nanavati et al. Have found large variation in the finishing of the edge of the IOL. In our study, only 4 PMMA IOL had 360 degrees square optic edge, and rough optic edge was detected in 7 IOLs. Surface irregularities, roughness, especially on the optic edge and optic haptic junction of PMMA IOL, may lead to unobstructed proliferation of migrating early cells, leading to increased incidence of PCO. To conclude, scanning electron microscopic analysis of 14 IOLs showed moderate to severe degree of surface and edge defects in all 40 IOLs. 93%, that is 92.9% irregularities were detected at the dialing holes and 78.6% at the optic haptic junctions. And we believe that these surface defects may contribute to a higher incision of PCO in SICS operations where PMMA IOL is implanted. At 160x, central optical zone was free of defects, and we believe that stringent manufacturing standards need to be enforced while manufacturing these IOLs. We acknowledge the assistance received from the CIF department at IIT Guwahati. These are some of the references. Thank you very much.
Thank you. Have you studied the clinical difference or outcome in the result, post-operative result of the, you have highlighted the irregularities in the manufacturing of the, not as part of this study.
But this is not a clinical study, but we next part of our study will be on the clinical. This process is still going on.
Okay. Thank you.
Please.
The announcement for the paper, best paper in our last session was the next general pupillality device by Dr. Bhattacharya. Thank you.
Now the next paper is by Dr. Ramesh Shah, my new design differential multifocal.
mode. Now it's taking the voice mode. Chairperson, ladies and gentlemen, this is my financial disclosure. This presentation is about first attempt by me to create near perfect diffractive multifocal IOL, active RC. Principally, success of diffractive multifocal IOL depends mainly on angle of incident ray on whole diffractive surface in vivo for distance and near separately. It should be same in vitro and vivo. In diffractive multifocal IOL, parallel rays of far vision is focused mainly on fovea and part of it gets focused in front of the retina. For near vision, divergent rays are split to focus mainly on fovea for near and partly behind the fovea. Far vision incident rays are parallel and near vision incident rays are divergent. This is accounted for first time in my design of diffractive multifocal IOL. For distant vision, pupil size is approximately 5 mm. So, 5 mm of cornea and IOL takes part in focusing image. While for near vision, pupil is approximately 3.75 mm. So, only 3.75 mm of the cornea and IOL takes part in focusing image. Human cornea has different corneal spherical aberrations for distance and near vision. For far vision, 6 mm cornea has approximately 0.25 to 0.35 of spherical aberration. So, we need IOL to correct the spherical aberration for distance. During reading, we need to correct spherical aberration of 3.75 mm of central cornea, which is 1/5 of 6 mm of the cornea, and that is near zero. Active RC, my own design, has taken all these physics into account to compensate corneal spherical aberration for far and spherical aberration for near separately on the same surface. During far vision, especially driving in dark condition, pupil is dilated and so we need maximum optics that can focus more light for far and least for near. 3.75 mm central diffractive surface will give more peripheral mono-optics for far. This will reduce the night vision problem. So, I decided to reduce the diffractive portion to 3.75 mm only. During reading, we need only 3.75 mm optic. So, we do not need optic for near beyond 3.75 mm. Hence, 6 mm full surface diffractive optic for near vision is not required. These are features of active RC. It has 6 mm of optics and 13.5 mm overall size. It has 3.75 mm central diffractive optics. It is not an apodize. Hydrophobic material and wet delivery system. 200 eyes are implanted so far with active RC with minimum 6-month follow-up. All perfect surgery patients are selected. 40% of the patients have best corrected visual acuity of 6/4 for distance, and almost all of them have 6/6 or more for distance. 10% of the patients have near vision of N5 with +1 addition. Rest have N5 without any addition. All of them have good speed of reading. 4 patients have mild halos. To conclude, Active RC is first diffractive multifocal design IOL by an Indian surgeon. I have tried to make as perfect design as possible to overcome shortfalls of the previous multifocal IOL. I thank biotech company Ahmedabad, India to help me to design Active RC IOL.
Thank you so much.
That's a good paper, but have you studied the photopic phenomenon occurring in these patients who have been implanted with this lens?
Yes, sir. This is the result which is given only one slide because only 6 minutes ago. So I have highlighted the physics mainly, but photopic, what you are talking of the night vision problem which is there, only 4 patients of them had a mild hair loss and they have not complained up beyond 3 months. They were there in the first 3 months. The main idea is to reduce the amount of light distributions for distance and near according to the requirement, and hence I reduced the size of the optic for the diffractive zones and the maximum optics for distance. So the photopic phenomena which you are talking about is much less when you reduce the zone to 3.75 millimeter. When you have a full diffractive surface, the chances of getting the photopic disturbance is much more than when you reduce it.
There is another IO back from the Alcon restore.
It is apodized.
3.6 millimeter is the area where the near eye has been given. This diffractive zone, this is little bigger. So we would be expecting little more of the halos and others. So isn't that?
What is happening in this case is that to 0.17, I don't think is very significant. The whole idea of 0.1 increasing by 0.17 is to improve the quality of vision for near also. So this is one compromise where we are trying to make as near perfect multifocal. Whatever the previous drawbacks were there, whether it is Alcon, it is acrylic or any other lenses, these lenses have mainly focused on a differential corneal asphericity for near and distance. This is one lens which has got differential corneal asphericity on the same surface of the lens.
And as it is not apodized, you say,
Yeah,
it
that
will
means
not include.
No, it is not increasing the height from center to the periphery. That is the first part. Second thing is you cannot manufacture. I repeat, I am involved in manufacturing the multifocal lenses for last 4 years. I have visited almost all the factories in the world except Alcon. You cannot manufacture a multifocal lens without a minimum apodization. When you go from the center to the periphery, you have to compensate the angle of incidence. In the periphery and centrals are different. So the height is slightly less when you go in the periphery, not that much as what the Alcon has done it. In this also, the height of each Maya is same from center to periphery. That is why this is not an apodized lens.
Thank you, Dr. Shah.
Thank you very much. Now I request Dr. Rohit Kapoor will be presenting changes in endothelium after administration of intracameral injection of moxifloxacin. This was the best paper, UP State Ophthalmics Conference.
Good morning, everyone. My topic is changes in endothelium after administration of intracameral injection of moxifloxacin following cataract surgery. Now we have come a long way from ab interno Van Graaff incisions to microincisional cataract surgery, and during this long journey we have not only tried to limit the length of our incisions, but we have also tried to limit the amount of complications which result as a result of cataract surgery. Complications of cataract surgery may be few and relatively infrequent, but may potentially result in complete loss of vision. Although rare, endophthalmitis is one dreadful complication of cataract surgery. Recently, intracameral injection is viewed with increasing interest for the benefits of providing an instantaneous high level of antibiotic in the anterior chamber after cataract surgery to prevent post-operative endophthalmitis. Various drugs have been used for this purpose, latest being the use of intracameral moxifloxacin. Endothelial toxicity is related to the chemical composition, concentration, pH, osmomolality that come in contact with the endothelium, resulting in localized endothelial damage. This study evaluated the safety of injecting intracameral moxifloxacin in eyes undergoing cataract surgery. Aims were to find any changes in thickness of cornea, to find any significant change in the endothelial cell count, and to find any morphological changes in the endothelial cells on giving intracameral injection of moxifloxacin following cataract surgery. 50 cases underwent planned cataract extraction and were randomized into 2 groups of 25 each. Group A comprised of 25 patients which underwent phacoemulsification with foldable IOLs with intracameral injection of moxifloxacin, and Group B comprised of 25 patients who underwent phacoemulsification with foldable IOLs without intracameral injection of moxifloxacin. All cases underwent a detailed preoperative evaluation including slit lamp examination, pachymetry and specular microscopy. All cases of cataract surgery with phacoemulsification and with foldable IOLs were included in the study, whereas patients with any corneal pathology, with any significant intraoperative complications like PC tear, with any cases of old uveitis, glaucoma or posterior synechiae were excluded from this study. Phacoemulsification was performed under peribulbar anesthesia and a foldable IOL was implanted, and 0.1 ml of moxifloxacin was injected through the side port as a last step of surgery under the distal capsular access edge with a final spurt of injection at the incision site, making sure the AC was left pressurized and no subconjunctival steroids or antibiotics were injected. Patient's preoperative and postoperative specular microscopy was done by specular microscope, and endothelial cell density, coefficient of variation in cell area and hexagonality were measured. Corneal thickness was measured by a pachymeter. This is a graph showing endothelial cell count of both groups preoperatively and postoperatively. As shown, there are no significant changes in moxifloxacin group as compared to the control group. This is a graph of the central corneal thickness of both groups preoperatively and postoperatively with no significant changes in the moxifloxacin group. This is the graph showing CV of size of both groups with no significant changes in the moxifloxacin group, and this is a graph of the hexagonality, again shows no significant changes in the moxifloxacin group. This is the photograph of specular microscopy of a male patient of moxifloxacin group preoperatively and postoperatively. No cases of adverse drug reaction was seen in any eye of study group, and no cases of postoperative infections in any eye, neither group was seen. In study conducted by Schonstein NH, effect of intracameral moxifloxacin on the rate of postoperative infection was evaluated in 2038 patients. Only one case of endophthalmitis was seen. Ashnaf in 2007 reported that in over 3,000 cataract procedures, after intracameral moxifloxacin, low endothelial cell loss was observed. The difference was non-significant as compared to eyes with no intracameral injection. Bernie J. et al. In 2009 conducted a study in 500 patients and found moxifloxacin to be non-toxic in terms of visual rehabilitation, anterior chamber reaction, and corneal edema. Most of the studies evaluated the prophylactic role and effect of drug on endothelial cell count and thickness. But our study takes into account the endothelial morphology as well, making it a unique and an innovative study. In conclusion, I like to say intracameral moxifloxacin seems to be a safe drug in terms of corneal thickness, endothelial cell density, and endothelial morphology for the use of cataract surgery as prophylaxis against postoperative infections. Thank you.
Any questions?
Which moxifloxacin is not?
Well, I have used Kitmox unims of Provis, and which come under Provis, which are manufactured by Provis company.
The next speaker will be Dr. Soumya Ganesh. He will be talking on unilateral axial myopia in atoms following trauma.
Next presentation, please be ready. Dr. Soumya.
Very good morning. My presentation today is on the comparison of optical quality of a piggyback multifocal IOL with that of a primary multifocal IOL. We have no financial disclosures today. A 63-year-old male presented to us with cataract in his left eye and a history of surgery in the right eye with a monofocal aspheric IOL being implanted. The patient was very keen on spectacle independence. So the obvious plan for his left eye was a cataract surgery with implantation of a multifocal IOL because he was very keen on one. But the question was, what could we do for his right eye? One option would have been to explant the IOL that he already had and implant a toric multifocal IOL. But like we all know, explantation comes with its risks, and toric multifocal IOLs were not available in the market at that particular time because of some licensing issues that the companies had. The other option could be an intracorneal implant, but this was not something we were doing in our center at that point or even now. The third option that we had was to implant a sulcus fixated piggyback multifocal IOL lens with an opposite clear corneal incision to compensate for the astigmatism, and this is what we went with. So this is the video showing the procedure being done. Initially we marked the axis for the incision and the opposite clear corneal incision that we had planned. Once that is done, all one has to do is inject the multifocal IOL, the sulcus fixated multifocal IOL into the eye, and then simply dial it in place. So these are the post-operative images of the patient 1 month after surgery. The patient was very happy. He had 6/6 vision in both eyes. But of course, he maintained that the vision in the right eye, which was the eye with the piggyback IOL, was not as crisp as that with the primary multifocal IOL. So this triggered us to conduct the study. We wanted to compare the optical quality of vision between the two eyes. So our aim, like I said, was to compare the optical quality of a secondary piggyback multifocal IOL. In this case, it was the Sulcoflex by Rayner, with that of a primary refractive multifocal IOL. In this case, it was the Restore. So we compared the patient's optical quality on 4 machines. One was the OPD3 scan by Nidec, the iTrace machine by Tracy Technologies, the C-Quant, which is a stray light meter by Oculus, and the optical quality analysis system by Visuometrics. So if one can see here, these are the scans of both eyes before the Sulcoflex was implanted. So both right eye and left eye show an equal amount or a comparable amount of total higher order aberrations, and the corneal higher order aberrations also are quite comparable. This is these are the scans of the patient after the Sulcoflex was implanted in the right eye. If one can notice, the total higher order aberrations in the right eye have increased to 0.396, whereas the corneal aberrations remain the same and comparable in both eyes. This is the eye trace of the same patient with the Sulcoflex IOL. Like one can see, the internal optics show higher order aberrations, which translate to the total higher order aberrations in the right eye. The left eye, the higher order aberrations are within normal limits. So we did an optical quality analysis system, and we analyzed the patient's objective scatter index, the modulation transfer function, and the Stirls ratio on the OCAS. So what you can see on the left is the piggyback Sulcoflex IOL. If one can notice, there is a lot of diffraction of light and it's not coming to a point focus, whereas the eye with the primary multifocal IOL is focusing better. So the optical scatter index is much more in the eye with the piggyback IOL, which means it's not doing as well. Similarly, the modulation transfer function also was better in the eye with the primary multifocal IOL. A C-Quant examination was done to analyze the intraocular light scatter. Both lenses did comparably well on the C-Quant. Earlier studies on image quality measured mostly vision and contrast sensitivity, and they have found no great disadvantages with the piggyback multifocal IOLs. And some studies also found that piggyback Sulcoflex IOLs did marginally better than the primary multifocal IOLs in conditions with high spatial frequencies. So in conclusion, in our study, we found that the primary multifocal IOL fared better than the add-on multifocal IOL. This might be a good option for patients who have already undergone monofocal IOL implantation and want spectacle independence. But however, it's very important to have proper pre-operative counseling, and the patient should be able to accept the fact that his vision might not be as good as an eye with a primary multifocal IOL. And considering the poor optical scatter index and modulation transfer function, it should be used with caution in those who drive extensively at night, but then this would also hold good for people who are considering even primary multifocal IOLs. Thank you.
Thank you. Do you have any opacification between the two lenses?
No, sir. So opacification was seen mostly in cases where both IOLs were implanted in the bag. But the Sulcoflex IOL that is implanted is a piggyback lens that's implanted in the sulcus. So if at all, the primary IOL might have an opacity, posterior capsular opacity, but no chance of an interlenticular opacification due to the design of the IOL itself.
Between the two IOLs?
No.
No,
Can
sir.
you use YAG then and clear it up? Any idea?
If it is interlenticular, unlikely, I would think. But posterior capsular for the primary monofocal IOL, yes, definitely it can be done.
You have operated any bilateral sulcoflex?
I'm sorry, sir?
Bilateral sulcoflex?
No, sir. We haven't done bilateral sulcoflex. In
Because
fact,
they
this
have
was the
the-
only sulcoflex that we have done until now. We have another patient who is lined up for surgery, but we haven't done it yet.
Because the difference between monofocal and multifocal of the contrast sensitivity. Same will carry with the sulcoflex also, because then now you have, as you discussed, with the optical quality.
Yes, but previous studies, however, have not analyzed the optical quality per se, but studies have analyzed results of sulcoflex, bilateral sulcoflex IOLs, and they have found that as far as the vision and contrast is concerned, sulcoflex does pretty well, but we of course have not done it, so I cannot comment from our experience.
So giving the choice, definitely one will prefer the multifocal,
Primary,
one
yes.
first.
Yes, we would prefer to do a primary multifocal,
Primary
but
multifocal.
only in cases where the patient already has a monofocal, probably we would give this as an option.
Was there any complication in these patients, especially like you put secondary IOL later? So in that case, maybe some adhesions were there. So is what it was possible to implant in all the cases?
Yes, if there is an addition, you mean an irido-lenticular addition or something like that, that's already there in the primary IOL, in the monofocal IOL. One would have to release the adhesions and then go ahead, I think. But as a procedure itself, the sulcoflex is very simple. As in the cataract surgery is already done. So all that one has to do is just inject the IOL and rotate it in place. But if a multifocal IOL is used, then we would have to center it well in the eye, which would be a concern.
Thank you very much.
Thank you, sir.
Now we request next paper, unilateral axial myopia in adults following trauma. Dr. Madhu Shekhar. I request the next speaker to be ready and keep the presentation ready.
Good morning to all. Good morning to all. I am going to present unilateral axial myopia in adults following trauma. We have no financial interest to disclose. Unilateral axial length elongation may occur in young adults with chronic traumatic cataract. In human as well as in animals, a severe visual deprivation in early life induces an axial elongation of the eyeball. Purpose of study to analyze the axial length elongation in patients who have undergone blunt and penetrating trauma and study the clinical relevance. It is a retrospective study, case selected during period of 2012 to 2013. It was divided into two groups, blunt and penetrating trauma, and 15 cases were selected in each group. Contralateral normal eye served as control group. Unilateral trauma with axial length elongation presenting between 2012 to 13 at Cataract Clinic, Arvind Eye Hospital, Madurai were included in this study. Patients with only unilateral axial length record, duration of trauma less than 1 year, congenital cataract, and those with bilateral trauma were excluded from the study. Parameters taken were base corrected visual acuity, axial length of both eyes, IOL power, history, duration of trauma, type of trauma, status of eye. Trauma and other eye were compared using Wilcoxon sign Ransom test. Penetrating trauma and blunt trauma group were compared using Mann-Whitney U test. Mean age of presentation in both penetrating and blunt trauma group was around 33 years. Around 36.4% of patients suffered trauma below 15 years of age. Around 46.7% patients suffered trauma more than 15 years of age. In both the penetrating and blunt trauma group, male suffered trauma more than female. Mean axial length elongation in penetrating trauma was around 26.5 mm as compared to 23.07 mm in fellow eye, and the difference was statistically significant. Mean axial length elongation in blunt trauma group was 23.6 mm as compared to contralateral eye, it was 23.22 mm. Though the difference was less, but it was also statistically significant. Mean axial length elongation in the overall trauma group was around 24.83 millimeter. As compared to fellow eye, it was 23.14 millimeter, and it was statistically significant. To summarize, in axial length elongation in penetrating trauma group was around 26.5, ranging from 23.76 to 29.96. In blood trauma group, mean axial length elongation was 23.60, ranging from 22.27 to 25.04, and mean axial length elongation was more in penetrating trauma as compared to blood trauma. All patients had elongation in their injured eye compared to other eye in our study. Multiple mechanisms for progressive ipsilateral elongation include trauma, age at surgery, duration and severity of vision deprivation, amblyopia, IOP changes, changes in scleral rigidity, and multiple surgeries. The induction of traumatic cataract usually requires a very forceful blow to eye, and it may be the trauma itself that starts the elongation process of the globe, and it may be complementary to visual deprivation. Comparing with other studies, previous studies, we have largest sample size, and we have compared blunt trauma with penetrating trauma, and axial length elongation was comparable with other studies in penetrating trauma. We found out that elongation of eye wall is significantly more in penetrating trauma than in blunt trauma. Younger the age of trauma, greater the magnitude of post-traumatic myopia. Despite of IOL implantation at an early age with good visual recovery, there was significant progressive axial myopia. Therefore, we can deduce that the nature of trauma is strongly related to axial elongation, and visual deprivation might only be contributory. The drawback of a study that we were not able to show any correlation between degree of elongation and the interval between trauma and surgery. It would thus be prudent to target myopia in such patients undergoing surgery, especially in penetrating trauma, to avoid post-operative refractive surgeries. Thank you.
Was there any location of injury in penetrating injury significant for this elongation, like corneal injury or corneal scleral?
Most of the patient has corneal along with lens injury.
Cornea versus sclera, like only corneal and other patient having scleral also. So was there a difference of elongation between the two?
We have not found that yet.
What could be the reason of more elongation in axial length in case of penetrating injury? Is it related to the severity of visual loss or something else?
There is no definite theory there. It has been there, sir. But in penetrating trauma might be due to that direct entry into the eye wall. There is more elongation is there than in blunt trauma. But there is no definite.
Thank you. Thank you.
Thank you.
Now, I request the next speaker, assessment of wound morphology and architecture in phacoemulsification using anterior segment OCT. Dr. Kiran. Now, Dr. Kiran Nandar, peristaltic and venturi pump based phacoemulsification system at high altitude. I request the next presenter to be ready, please. That is Dr. Saket Benua. You there?
Good morning, ladies and gentlemen. I present our study on comparative evaluation of peristaltic and venturi pump based phacoemulsification system at high altitude. This is a part of a Armed Forces Medical Research Committee project. The funds were allotted by Government of India. However, we don't have any kind of financial or any other interest with the equipment and consumables used in this study. As we all know, that the phacoemulsifier systems are the best performing for the cataract surgery, and they are tuned to work at the normal atmospheric conditions. However, their efficacy and evaluation at different heights, more than 10,000 feet, has not been carried out so far anywhere in the world, as we have gone into the literature, as well as we have got the input from the companies also, they have conducted the study laboratory conditions up to 9,000 feet. But on clinical studies, so far, never has been conducted. With this objective, we have designed this study at the altitude of 11,203, that is Leh, and 1,006 feet at the Tangsei, which is around 140 kilometers away from the Leh. This is a cross-sectional comparative study. It was carried out in the eastern Ladakh as mentioned in the phased manner in June 11, October, and then in June 12. In each phase, a place with higher altitude was chosen. We have performed surgery in 160 eyes with uncomplicated cataract, and this was performed with the help of either venturi or peristaltic machines in the random manner in every phase. The phase 1, which was conducted at Leh, we have 110 eyes, where 62 were in the peristaltic, remaining on the venturi system. Phase 2 was at the Tangsei, where 37 eyes were on the peristaltic system, and remaining 13 eyes were operated on venturi system. The results were compared with the parameters used by us at the ground level, that is in Delhi at 340 meters, and it was analyzed. Inclusion criteria, we have a moderate to grade 2 to 4 cataracts, and assessments in the study was done by the single surgeon. A local informed consent was prepared in the local language. Intraoperative parameters like total height, vacuum, flow rate, etc. were recorded for each step of central phaco-chop technique. The surgery was done in the June to November, where these are the non-winter months, to avoid the extreme cold. In October, in 14,000 feet height, the outside OT temperature was -5 to -10, and inside the OT with heating elements, we were able to manage between +5 to +10. These are the results on the bottle heights at different altitude. So we have the comparison, and if you can go through here, that in the Delhi we had a static height of around 75 centimeter, whereas for the various stages for the peristaltic pump, in Leh it was going 93.54 to 103, whereas for the Tangsei it was further around 15 to 20% was higher, and for the venturi it was definitely required more than the which is done for the peristaltic system. When we go for the flow rate for the peristaltic system, at the ground level, it was ranging from 21 to 33 millimeter cubic centimeter per minute, whereas for the Leh, it was ranging from 38 to 43, and for Tangsei, it required a higher flow rate of 46 to 52. Now, this was the reason that you have to go with the higher flow rate, which is not possible in the venturi system. The efficacy of the venturi system was not as good as it was found with the peristaltic system. These are the different vacuum settings. If you compare here on the vacuum, in our system in Delhi, we were working on the linear mode 234 to 386 for the different stages. For Leh, it was 409 to 510, and for Tangsei, it was 428 to 560. Whereas in the venturi system, it was again, there was a parallel trend from 272 to 297 in Leh and 307 to 492 at the Tangsei, that is the 14,000 feet height. However, so far the ultrasonic energy utilization was concerned, there was no significant difference in the using the energy. All surgeries were performed under topical propofol anesthesia, and surgical time was ranging from 8 to 10 minutes. These were the certain other observations which is linked with the iris blocking the well-constructed phacotunnel, as well as the another important thing was the self-propulsion of IOL while it is being pushed into the anterior chamber. Moment a slight push is there and the push is withdrawn, the IOL passes through automatically due to the varying in the atmospheric pressure and it's self-delivered. The success of surgery is based on the optical equilibrium achieved in the fluidics and US energy that we all know. How the high altitude alters the fluidic system is there. The normal atmospheric pressure is around 760 at the sea level and it is around 755 in the North India. When we go to the 11,000 feet of the height, the atmospheric pressure reaches lower down up to the 580, whereas in the 14,000 feet it goes up to the 550 or so. So when there is a variations in the atmospheric pressure, whatever the gradient you achieve in dynamics, it cannot exceed the normal atmospheric pressure. So these variations of around 15 to 20% definitely require a higher settings to achieve optimal efficacy of the system. The second option remains there in the compliance in the irrigated tubings. If we can have the altered tubings and the sensor, probably the difficulties of managing at the high altitude can be minimized. So the two most important factors remains there. One is the atmospheric pressure variance and second is the size of the tubings and their efficacy. Now peristaltic is a controlled one which is not associated much with the atmospheric sudden variations in the atmospheric pressure compared to the Venturi system. So the efficacy of Venturi is much lower than the peristaltic system. To conclude, the low atmospheric pressure is the main significant reason to have the problems in the surgeries and new parameters are required to be opted. Thank you very much.
Thank you very much. Next speaker please. Dr. Sakit Benuar on clinical outcome of toric IOL implantation for correction of pre-existing corneal astigmatism.
Question with Colonel Pariha. Yeah.
Any question? In this phacoemulsification, we have a silicone tube, I think, with the Venturi system. Venturi system, almost all of them have the silicone tubing, or it's a disposable tubing.
These all are disposable tubes. It does not affect. It is basically the lumen, the size which may affect.
Thank you, Colonel Pariha. Next speaker, please be ready. Dr. Siddharth Mehta.
Hello. Good morning, everyone. I am Dr. Sakit Benura and I am here to present my study on the clinical outcome of toric intraocular lens implantation for correction of pre-existing regular corneal astigmatism. None of the authors has any financial interest in this study. According to various estimates, 15 to 29% of patients with cataract have visually significant corneal astigmatism, that is more than or equal to 1.5 diopters. Modalities for treating astigmatism included corneal incisions, limbo relaxing incisions, whose main drawbacks were that the outcome depended on multiple factors and there are numerous complications related to wound healing and dry eye. Toric intraocular lens implantation was introduced as an option for astigmatism correction in cataract patients in the late 1990s. The aim of my study is to evaluate the efficacy of toric intraocular lens implantation for correction of pre-existing regular corneal astigmatism cataract patients and determine any post-operative rotation of the eyes to detect long-term stability. This prospective study included 30 eyes from 24 consecutive patients with cataract and pre-existing regular corneal astigmatism who underwent implantation of a toric IOL with minimum 6 months follow-up. The inclusion criteria were visually significant cataract and pre-operative regular corneal astigmatism of 1 to 4 diopters. Exclusion criteria included irregular corneal astigmatism, pre-existing corneal disease, retinal pathology of any cause affecting vision, complicated cataract, any history of previous intraocular inflammation, glaucoma, intra-op or post-op complications affecting visual outcome. Pre-operative assessment included a complete ophthalmological examination, measurement of uncorrected visual acuity, best spectacle corrected visual acuity, manual refraction and auto refraction, slit lamp examination, intraocular pressure measurement, and direct and indirect ophthalmoscopy. The intraocular lens cylindricalized toric power and the alignment axis were calculated using a toric calculator program available from the respective IOL manufacturer. The data which we entered were the pre-op keratometry was calculated by manual keratometer. The IOL spherical power was obtained by optical coherence biometry. The incision location was temporal in all cases, and the surgically induced astigmatism was 0.5 in all cases as it was performed by one surgeon. The output from the program is the cylindrical, the toric lens power required, and the optimal axis location of the eye. This is an example of the pre-op information and the lens. Preoperative marking. Preoperatively, with the patient sitting upright, the reference corneal marker was used to place 3 limbal reference marks at 3, 6 and 9 o'clock positions. It was done in the sitting position to correct for recumbent cyclotorsion. Intraoperatively, the actual implantation axis was marked using a ring and an intraop toric axis marker. The cataract surgery was performed by one experienced surgeon using local peribulbar anesthesia. The video of the surgery. Clear corneal incision. Then continuous curvilinear capsulorhexis of 5 to 5.5 mm was performed. It is important to have a circular capsulorhexis. Then phacoemulsification was done by routine technique using a 2.8 mm clear corneal incision. Then marking of the alignment axis was done using an intraop marker and a spherical marker. Then the toric intraocular lens was inserted in the bag. The lens was then rotated clockwise around 10 to 20 degrees of the final alignment axis. After rotating it, the visco surgical device was removed. Visco was removed, taking care it is removed from behind the lens, and then the lens was finally rotated on the mount. Post-operative follow-up. Follow-up examinations were performed on day 1, day 7, 1 month and 6 months after surgery. This included uncorrected distant visual acuity, best corrected distant visual acuity, manual refraction and auto refraction to detect any residual refraction, manual keratometry, slit lamp examination with digital retinal image slit lamp photographs to detect any IOL rotation. Our results at final follow-up, that is at 6 months, 26 eyes out of 30 had uncorrected distant visual acuity of 6.9 or better. There was significant reduction in refractive astigmatism from 1.5 to 0.28 diopters. And there was no significant change in corneal astigmatism following surgery. So these are the 30 patients. It shows that there is significant reduction in the post-op mean refractive astigmatism. For the toric IOL rotation post-op, 1 month post-op, the mean toric IOL axis rotation was 2.2, a range of 0.6 to 5.1, and 6 months post-op, the rotation was 2.7, that is 0.9 to 5.9. The later rotation occurred between 1 and 6 months and was more than 3 degrees in 2 eyes only. No eye had secondary surgery to reposition the IOL axis within the 6-month post-op period, and there was no significant IOL rotation that is more than 10 degrees in any patient. This is a graph showing the IOL rotation at 6 months and 1 month. In our study, 75% eyes shows uncorrected distant visual acuity 6.9 or better at final follow-up, thus allowing for spectacle independence for the patients. The major requirement for toric intraocular lenses is rotational stability. The post-operative rotation of the toric IOLs in a study mostly occurred in the early post-operative period and minimally from 1 to 6 months. And no significant rotation that is more than 10 degrees occurred in any patient. Toric IOLs can provide a good uncorrected distant visual acuity to majority of patients with regular corneal astigmatism with cataract, thus providing spectacle independence. They show long-term rotational stability in the capsular bag. Thus, the results from our study show that phacoemulsification cataract surgery with implantation of a toric IOL is a safe, predictable, and effective long-term option for correcting pre-existing regular corneal astigmatism. Thank you.
Thank you. Any question?
How did you check the post-op rotation of the toric lens?
So, the post-op rotation, we followed up at day 1, day 7, 1 month and 6 months, and we examined them on slit lamp. And on slit lamp, we took photographs and depending on the axis. So on that, we determined the post-op rotation of the IOL.
But it was not good to mark the axis marking on the slit lamp also, so
yes.
Your evaluation will be better.
Yes, sir. If the marking was done on slit lamp, evaluation would have been better.
Because you are cross-checking on the slit lamp.
Yes, sir.
And the marking.
Yes, we did most of the markings on the slit lamp. Some. Thank you, sir.
Now I request Dr. Vinod Mehta.
Siddharth Mehta. Yes. Evaluation of manual marking for toric IOL using real-time tracking technology.
Yes, good morning everyone. So my topic is evaluation of the manual marking for toric IOL using the real-time tracking technology, the SMI surgical guidance system. We have no financial interest in this presentation. So we all know that toric IOL have emerged as a very safe and a predictive alternative in treating pre-existing astigmatism along with cataract, and thus providing optimum uncorrected visual acuity to our patient. But the success of toric IOL not only depends on accurate pre-op astigmatism measurement, but also on accurate IOL alignment. So IOL alignment is extremely crucial. Now the lenses can be misaligned if they are inaccurately placed, or there is a rotation, or both. Now rotation used to be an issue mainly with the silicone lenses. However, nowadays the lenses are hydrophobic acrylic material, and studies have shown that the rotation of such lenses is just about 1 degree at 6 months of follow-up. So the problem is not the rotation, but it is the inaccurate placement. Routinely, most of us use a 3-step procedure wherein we do the reference marking in a sitting position where 0, 180 is marked so as to compensate for the cyclotorsion, and then accordingly the IOL is aligned. But are these reference marking accurate? Now there are certain studies which have compared this reference marking, and they have shown that there is some amount of variation in all this reference marking. So to overcome these inaccuracies, there has been an influx of newer technologies such as the SMI surgical guidance system. Now this is a real-time tracking technology which helps as a good guidance for aligning an IOL. Now this SMI technology is a highly reliable unit. As mentioned in this study, there is a very negligible inter-observer variation. This is very accurate, and so with the help of SMI, we wanted to assess how our manual markings are. Thus, we decided to do a study wherein we wanted to assess the accuracy of all the 3-point reference marking for toric IOL using this SMI system. Ours was a very simple study. It was a prospective study where we evaluated 54 eyes. All underwent cataract surgery with toric IOLs. A single surgeon performed all the surgery. The first step was we did a manual 3-point marking using a bubble marker in a sitting position. This was done by a single person, a right-handed person. It doesn't go to the next slide. After which, the patient was then taken on to the reference unit. Now this is a unit of SMI, where this is the non-contact measurement device which took high-resolution images of the cornea. Then these registered images were matched with the microscopic images. There's a video here. I'll go ahead with the presentation. So the SMI images were matched with the microscopic images, and once they were matched, the alignment was done. And these were the representative images. As you can see, there are these manual marking and the overlay. Now, once both in the first representative images, you can see that the 0 very well coincides with the marker or the overlay, whereas in the second images, there is significant variation in both the overlay as well as the manual mark. So what we looked for was 2 things: the degree of deviation, whether it was less than 5 degrees or whether it was more than 5 degrees, and also the direction of deviation, whether it was in a clockwise or in an anti-clockwise variation. Moving on to the results, we had 54 eyes, and we had coincidentally equal amount of both eyes, 27 in each. So the first thing which we looked for is the degree of deviation. Now, the right eye had 44 degrees of deviation and 70% in the left eye, which was showing about 0 to 5 degrees of deviation. And the right eye showed significant amount of variation when it was more than 5 degrees. The second thing we looked for is the direction of deviation. 10 eyes, that is 18% of the eyes, were exactly showing no deviation at all. However, 48 eyes showed clockwise and 33% showed anti-clockwise. If we look only at the right eye, there is significant amount of variation in a clockwise in the right eye, whereas in the left eye, the clock and anti-clockwise variation is almost more or less the same. So from this we had concluded that the degree of deviation was significantly more with the manual marking as compared to the real-time tracking technology, whereas the direction in the right eye was more anti-clockwise, which showed the more error as compared to the left eye. So in conclusion, alignment is the most crucial aspect for the success of the toric IOLs. The most commonly used 3-point marker is highly variable and it shows inaccuracies. So we need to closely observe how we do our 3-point markings, and to minimize the errors, we need to use a superior technology such as the SMI, which will enhance our outcomes. These are my references. Thank you so much.
Thank you, Doctor. Any question?